Welcome back to Lecture 4 of our white blood cell unit. Today we are going to discuss myeloproliferative neoplasms. You may also hear it referred to as myeloproliferative disorders. And this is when too much of a good thing becomes a bad thing. So myeloproliferative neoplasms are interrelated clonal hematopoietic stem cell disorders characterized by excessive proliferation of one or more mature myeloid cell lines. So I think I did mention that there are a few areas in which there can be an overlap between a leukemia and a myeloproliferative disorder. And this is kind of where we're talking about in terms of that CML, because it is a proliferative disorder and the myeloid cell lines are mature. And we're going to see some specific examples of that as we move forward in this lecture. So the proliferation that occurs can be of granulocytes, it can be erythrocytes, maybe megakaryocytes, and or mast cells. Okay, so MPMs are at the core involved in dysregulation at the multipotent hematopoietic stem cell. These cells are CD34 positive, so cell marker CD34, and typically have one or more of the following shared features. And again, these are just general characteristics of myeloproliferative disorders, and it could be a combination of several. But very first thing that we're going to notice about myeloproliferative neoplasms are they are often associated with some type of cytogenetic abnormality. So there's going to be a genetic component, whether it's a translocation or a mutation, but that is very, very common to see in MPNs. We may also see an overproduction of one or more types of blood cells with dominance of a transformed clone. So there's going to be something that occurs to cause a cell to become clonal and start producing copies of itself. And this doesn't just happen with one cell. It will then, all of the clones that cell makes will then start making clones of themselves, et cetera, et cetera. So that's where that proliferative term comes from. We might see hypercellular marrow or myelofibrosis. So in the case of certain myeloproliferative disorders, the bone marrow becomes hypercellular, where you have an overabundance of cellular or hematopoietic tissue in the marrow, and others where the bone marrow looks kind of fibrous, it looks crunchy, it's almost like a scar tissue inside of the bone marrow with little or no hematopoietic tissue there. And often in the case of myelofibrosis, when a bone marrow tap is performed or bone marrow biopsy, when they go in, they aren't able to extract any good marrow because it's just crunchy and kind of dried out. It's like a tumbleweed inside. And so we call that a dry tap. And that's something we see very, very often in fibrotic bone marrows with these myeloproliferative neoplasms. We may have thrombotic and or hemorrhagic bleeding, so either blood clotting or hemorrhaging. We may see extramedullary hematopoiesis, and what that means is we are going to see a production of blood cells outside of the bone marrow, and this is usually because maybe there's inadequate productions, maybe there's in the marrow, maybe there's a fibrotic bone marrow, and that can occur in the spleen, in the liver, and the lymph nodes. But generally speaking, that's kind of a way our body tries to compensate. And of course, we know that our body will do anything that it can to keep us alive and keep us thriving. And in this extramedullary hematopoiesis, that is our body's way of trying to divert the mechanisms to allow us to have enough proper blood cells. And unfortunately, some of these myeloproliferative neoplasms can transform into an acute leukemia. So remember, we have that threshold where in order to be classified as an acute leukemia, we have to have equal to or greater than 30% blasts in the bone marrow. And what we're going to typically see when that transformation happens is the patient will be pretty stable, and then all of a sudden they'll have this really acute aggressive form of leukemia associated with their initial myeloproliferative disorder. So let's look at a few of our culprits. Now, we have already mentioned CML. It is classified as one of our chronic leukemias. In this case, it is a chronic myelogenous or myelocytic leukemia. We also have polycythemia vera. Next, we have primary myelofibrosis. This has a couple of other names. You may hear agnogenic myeloid metaplasia, AMM, or myelofibrosis with myeloid metaplasia. All of those terms are interchangeable. And then last but not least, essential thrombocythemia. Okay, so let's take a look at some of the differences between these myeloproliferative neoplasms. Let's start with CML since we've already kind of talked about it. So remember, when we have a chronic myelogenous leukemia, we're going to have a much higher white blood cell count. So our leukocytes are going to be extremely increased. Our erythrocytes will be decreased because of that overproliferation of the white cells. Platelets may also be moderately increased. Teardrop-shaped erythrocytes, that's really not going to be present in CML. We're going to talk a little bit more about a leukocyte alkaline phosphate score. That's going to be, we also call that a LAP score. That will be decreased in CML. So we'll talk more about the LAP score later, but it is one of the determining factors as to whether we are looking at a CML or something called a leukemoid reaction, but more on that later. And then myelofibrosis, we might see some variability in that depending on the phase that it is in. And then there's something called the Philadelphia chromosome, and it will be positive. CML is the only myeloproliferative neoplasm that is positive for the Philadelphia chromosome. And we'll talk more about that in just another minute. I know I keep saying that, but right now we're just getting a brief general characteristic overview. But as we get into investigating each of these myeloproliferative disorders individually, we'll get more details. All right, primary myelofibrosis. Well, we are going to have a decreased erythrocyte count, so our red cells are going to be low. Platelets and leukocytes are variable. It really, again, depends on how advanced the disease state is. One of the hallmark cells of primary myelofibrosis are teardrop-shaped erythrocytes. Now, we see this in some types of anemia, but in terms of the myeloproliferative disorders, this is going to be a hallmark cell. And again, it's because that fibrotic bone marrow, as the red cells are trying to exit the marrow and go into circulation, it stretches and pulls those red cell membranes into a teardrop shape. So our leukocyte alkaline phosphate score is going to be variable with PMN, not PMM, primary myelofibrosis, sorry about that. And then we're going to have an increase in myelofibrosis. So that's kind of, if you think about the name myelofibrosis, that's because it has a very, very increased marrow fibrosis. And then it's going to be negative for that Philadelphia chromosome. In terms of our polycythemia vera, we're going to see very increased erythrocyte count because this is a proliferative disorder of the red cell line. We're going to see an increase in leukocytes as well, a moderate increase in platelets. There's not going to be any morphology issues, but there will be an extremely increased LAP score. There's not going to be any myelofibrosis associated with the PRV or the polycythemia vera, and it will be negative for the Philadelphia chromosome. Now, essential thrombocythemia, or ET, we're going to have normal leukocytes, normal erythrocytes, but our platelets are going to be crazy increased. We're not going to have any morphology issues. We might have a normal LAP score, or it might be increased. No myelofibrosis is associated with essential thrombocythemia, and it is also negative for that Philadelphia chromosome. So looking at some other characteristics of myeloproliferative neoplasms, generally we're going to see a demographic of adults between the ages of 50 and 70 years of age, so an older demographic or a more mature demographic. These MPNs are going to have overlapping clinical features, so they will have some features that are the same as other myeloproliferative neoplasms, but they will have some things that are specific just to them. Approximately 2/3 of patients whose illness transforms into acute leukemia develop myelogenous leukemia. So we're looking at a transformation from a myeloproliferative disorder to an acute leukemia. And again, we're going to be monitoring these patients and watching to make sure that we're not seeing a higher instance of less mature cells. Because remember, these are typically a proliferation of mature cells. It isn't until we get to proliferation of immature cells that we have an acute leukemia. Of those 2/3 of patients whose illness transforms into acute leukemia, there will be a third that develop lymphoblastic leukemia. So it'll be a part of the lymphocytic line. And then, of course, median survival time from diagnosis of the acute transformation only averages about 3 months. And sadly, it's just so aggressive and often it goes undetected. That's why we monitor these patients so closely and try to catch it early on. However, patient compliance is a big issue with regard to making sure they go to their appointments, having their lab work done, in general, just not becoming complacent. So let's go back to our CML, which is classified as a myeloproliferative disorder and a chronic leukemia, specifically chronic myelogenous leukemia. So what we're going to see in CML, again, is that proliferation of granulocytes. There might be many immature granulocytes seen in the peripheral blood and the bone marrow, but the majority of these cells are going to have some degree of maturity. So if we look here, we're going to have we'll have some bands, we'll have some mature granulocytes, we'll have some metamyelocytes, some myelocytes, varying degrees of all of those granulocytic types of cells. This particular condition, CML, is associated with the BCR-ABL1 fusion gene located in the Philadelphia chromosome. CML and CLL are the principal types of chronic leukemia, which we did already discuss in our leukemia unit, and it is predominantly a leukemia of middle-aged adults. Now remember, some of these can fall into both category of myeloproliferative disorders or even a lymphoproliferative disorder in the case of lymphocytic leukemia, but don't be confused. This is still considered a chronic leukemia of a myelogenous lineage, and we're going to see kind of some immature, a good mixture of mature and immature cells here. Okay, so when looking to diagnose CML through cytogenetics, the very first thing that we may look for is something called that Philadelphia chromosome. And this is really the first chromosome described in a malignant disorder. Most Philadelphia chromosome positive patients have the typical translocation at 9 and 22, and you can see it over here on our karyotype graph or picture. And then the ABL gene product is a protein tyrosine kinase and the fusion protein BCR-ABL. It has constitutive kinase activity, and that deregulates signal pathways. So that causes abnormal cell cycling and inhibition of apoptosis. So in addition to an overproliferation of cells, not only that, but the cells that are living are being inhibited from their own self-destruction. And then just again, an increased proliferation of those cells. Okay, so when evaluating CML, what we typically see is a transition through a few phases. Initially, we have that chronic phase, and this is where we have the onset of the early or initial phase of CML, and it's pretty gradual with regard to its development. It might last for 3 to 5 years, and again, that varies from patient to patient. And it's at this phase where about 80% of cases are diagnosed. As the chronic phase moves forward, it may move into an accelerated phase. We have, in this case, with regard to our lab results, we may have a rising peripheral blood count so the WBC blood count is going to be increased. We might have circulating blasts, and in the bone marrow, we're going to see about 10 to 30% of blasts. We will see an increased percentage of basophils, like more severity or worsening anemia, and thrombocytopenia. And the accelerated phase can last for a varying degree of time. Usually it's much, much shorter than the chronic phase. And then it will move into what we call an acute phase or a blast crisis. Now, this is characterized by the appearance of blast cells like those we see in acute leukemia. And when we have a greater than 30% in a blast crisis, we are then transitioning into an acute leukemia. At this phase, though, it's very difficult to determine whether it's actually transitioned or not. And really what we're going to be looking for is that Philadelphia chromosome through cytogenetic testing, and that can help aid in the differentiation. The higher the percentage of blasts that we see, the worse prognosis. And a lot of times this actually does transition into an AML. It just, we just have to kind of monitor it, and if we see an increase in blasts or blasts in circulation, obviously we would need to determine if this is now in a blast crisis. So one of the things that we really want to keep in mind when we're looking at CML is the prognosis. And depending on the time frame or the phase that the CML is in during diagnosis is going to kind of predict the outcome for that patient. So again, about 85% of the cases of CML are diagnosed during that chronic phase. And at that point, CML is highly treatable. We treat with monitoring, supportive care, and chemotherapy. Once we get into the accelerated phase, though, we have a shorter period of time in which that phase lasts. And it's really during this time when we start to see chemotherapy resistance developing. And unfortunately, blast crisis or that acute phase, which lasts only about 3 to 4 months, is generally unresponsive when treated with chemotherapy. So imagine if you were a patient and you go into your doctor and all of a sudden they're like, oh my goodness, you have a bunch of blasts and you start having chemotherapy and you're having a general unresponsiveness to that chemotherapy. You might only have 3 to 4 months to live. So that it would be a very poor prognosis. Whereas if you were diagnosed in the chronic phase and treated with chemotherapy, you may have a very good prognosis. All right, so let's look at some of the laboratory data that we may find in a patient with CML. First and foremost, one of the first indicators is we're going to have a pretty significantly elevated white blood cell count. Now, this is not going to be as significant in the chronic phase as it would be in the other phases, but it's typically still higher than you would see in a perfectly healthy individual. So usually it's going to be greater than 50 and may even exceed 300. It's crazy. We're going to see many neutrophils and immature granulocyte forms seen in the peripheral blood and bone marrow. That's because there's such a proliferation happening that a lot of these cells are sent out into circulation because there's just no room for them in the bone marrow anymore. So we're going to see promyelocytes, myelocytes, metamyelocytes, bands. But the important thing to remember is there is maturity happening here. So when you think of CML, we're talking about more mature cells in chronic myelogenous leukemias or myelocytic leukemias. This simply means that maturation is happening, but we're not looking at, 80 or 90% blasts like we would in an acute leukemia. Next, we're going to see eosinophils and basophils. They may be decreased or increased as well because, again, they're granulocytes. And then we have blasts, which may be seen in the accelerated or blast crisis. Now, generally speaking, if you look at this picture right here on the slide, this is not in an acute phase. I would say this is probably more in the chronic phase because we're seeing a variety of various phases of development of these granulocytes. If this were to be in the accelerated or the blast crisis phase, we would see less maturity and we would see maybe more blasts. So anemia is common, and that is obviously because even though we have a hypercellular bone marrow, we are still crowding out healthy bone marrow precursors. So red blood cell precursors are going to be crowded out by granulocyte precursors. We're going to have an elevated platelet count. And then again, this hypercellular bone marrow with an elevated ME ratio up to 25:1. Now, we haven't really talked too much in depth about what an ME ratio is, but an ME ratio simply means myeloid to erythroid ratio. And a normal ME ratio is about 3:1 or 2.5:1. So for every 2.5 myeloid precursors, you're going to have one erythroid precursor. Why is that? Well, because red blood cells go into circulation, they live for 120 days, whereas these myeloid cells, whether they're monocytes, neutrophils, eosinophils, basophils, whatever, they leave or they migrate out of circulation to the tissues. And while they're there, they might be fighting infection. They might be become resident macrophages in the tissue or whatever, doing their white blood cell jobs. And so fewer of them are in circulation. So they have to be replenished more often. And that is why we have a higher ratio of myeloid to erythroid precursors in the bone marrow. So again, that normal ME ratio is 2.5 myeloid to 1 erythroid. But in the case of CML, it can go as high as 25 to 1. So that would be for every one red blood cell precursors, you have 25 granulocyte. So it's pretty crazy. Or I guess myeloid would be the right term because technically monocytes are agranular, but you know what I mean, right? So similarly to AML and ALL, our two acute leukemias, we can use cytochemical staining in CML. And this can help us differentiate between CML and a leukemoid reaction. What is a leukemoid reaction? Well, I'm glad you asked. So, a leukemoid reaction is essentially a physiological response to infection or stress. And that can include an increase in the white blood cell count overall, but specifically the myeloid white blood cells. And this reaction to stress or infection can mimic a leukemia. And so we might see an extremely elevated white blood cell count in both in a leukemoid reaction and in a CML. We're going to see varying degrees of immature granulocytes in circulation, both in CML and in a leukemoid reaction. So we don't want to treat somebody with chemotherapy if really we're looking for a source of stress or infection. So what we can do is we can perform a lap stain, a leukocyte alkaline phosphatase test, or stain. Now, generally speaking, a lap score is normal to high in a leukemoid reaction. So they stain very well. They're going to have a heavier stain. And in a CML patient, their white blood cells are going to either stain low or absent in CML. So their stains are going to be resistant to this lap stain. So a normal lap score should be anywhere between 20 and 100. We'll talk about this a little bit more, and I will demonstrate on how to calculate your lap stain. But ultimately, after staining, 100 bands and segs are counted. So we're going to specifically look at the neutrophilic line. So bands and segs are counted and rated on intensity of staining from 0 to 4. The score is then calculated by multiplying the number of cells counted per grade by the grade and then taking the sum. So we're going to multiply the number of cells that we counted per rating, and then we'll add the column of all of the lap scores together to get the last sum. And let me demonstrate that on our next slide. Remember, also our leukemoid reaction is going to also sometimes be called a left shift, and that's going to be in response to severe inflammation, infection, and sometimes stress. So left shift, leukemoid reaction, lap stain. Okay, so here we have kind of a chart to show how to perform that calculation. So we're going to have a cell rating first of 0, which means it didn't take up any of the stain. Plus 1 would be a little, plus 2 would be a little bit more, plus 3 would be pretty moderate, and then 4 we would have a heavy staining. Then we are going to count the number of cells that meet the cell rating in each category. We will then multiply. So for example, at a 0 cell rating, we've counted 45. So 45 times 0 is going to be 0. We'll put that in our lap score for 0 rating. And then we had 30 that were plus 1. 15 that were a +2, and then 5 that were a +3, and 20. So now that we have our lap score under each cell rating, we're going just to add them together. And that's going to give us a total lap score of 95. Now, remember, if we go back, we're going to see that this is a perfectly normal lap score. So 95 is perfectly normal. Okay, so I know we have talked a lot about CML. We've talked about the myeloproliferation happening in the bone marrow. We've talked about the phases of transition that CML goes through. We've kind of talked about cytogenetic conditions associated with CML. So, for example, the Philadelphia chromosome. We've talked about the bone marrow, the appearance of the bone marrow. So we're going to have hypercellular bone marrow. We've talked about prognosis, and we know that if we catch CML in the chronic or initial phase, it is highly treatable, and the patient typically will have a great prognosis in the long term. So one of the drugs that has been introduced is called imatinib mesylate, or the brand name for it is Gleevec, and that has really changed and altered the management of patients with CML in the chronic phase. So what will happen is we give them this medication and it slows or stops the growth of those cancer cells. So proliferation will decrease. And it is recommended as the best single agent for newly diagnosed patients who are not eligible for initial treatment by allogenic stem cell transplantation. Now, remember, allogenic means from outside of oneself, so they're going to be looking at receiving someone else's stem cells for transplantation, and for whatever reason, they may not be eligible for that. So this is the best medication on the market for these patients, and it has a track record of success. So a long-standing and universally accepted therapy for CML is that allogenic stem cell transplantation. Gosh, guys, it's Monday. Patient monitoring at the cytogenetic and molecular levels is crucial for identifying disease stage and progression. So we're probably going to look at the bone marrow. We're going to look at that cytogenetic, the markers. We're going to also really watch and see how this patient progresses. And that's really kind of going to give us a better picture of the prognosis for this patient. So this is pretty much wrapping it up for CML for now. We're going to talk more about it later on when we talk about leukemoid reactions again. And remember, leukemoid reaction is just that physiological response to infection, stress, etc., inflammation. But definitely know how to make those, how to calculate those lap scores. Okay, now that we have discussed CML, let's move on to our next myeloproliferative disorder. So our next myeloproliferative disorder is called polycythemia vera, or sometimes you will hear it referred to as polycythemia rubra vera. Polycythemia vera is a clonal stem cell disorder characterized by hyperproliferation of erythroid, myeloid, and megakaryocytic lineages. But what we're really going to see is a predominant proliferation of erythroid cells. Again, we're looking at a more mature demographic in terms of diagnosis. The median age is about 60 years old with a slight male predominance. Now, if we look at the picture here on the screen, we are going to look to the left first. This will show us what a normal blood sample would look like if we were to spin it down. All of the red cells will be pushed to the bottom because they are more dense. Then we would have the white cells and platelets in that buffy coat. And last but not least, we would have the plasma on top where we have our water, proteins, nutrients, hormones, immunoglobulins, etc. And of course, this red area represents our hematocrit, which again is the percentage of the sample that is made up just of red cells. Now, if we look at the sample in the middle, we're going to see a decreased red cell count and a lot more plasma present. And this is because this patient is anemic and has a decreased hematocrit. And now if we look at this patient with polycythemia vera, we are going to see a much higher red cell count, a little bit, I mean, you can't really see it here, but they may even have a little bit more of a buffy coat because there's going to be some hyperproliferation of these of the myelocytes or the myeloid cells. And then you're going to have less plasma than you would in a normal sample. So here we are going to have an elevated hematocrit. So instead of, 40 or 50%, you might have 60 or 70%, or maybe even more. Patients with polycythemia vera have a variety of different clinical signs and symptoms. But the hallmark of PV is plethora, which is just a red, rooty complexion, as you can see in the picture there. It looks like little red capillaries that are kind of all at the surface of the skin. They may have splenomegaly, so congestion and enlargement of the spleen is often present. Reversible moderate hypertension, and this frequently occurs as the result of the expanded blood volume. So you have an overproliferation of erythroid cells in circulation that's actually going to cause your blood pressure to increase because you kind of have a hypervolemic issue in terms of you have too much blood volume. And again, you're going to have an increased total blood volume, which is called hypervolemia. You may even have neurological symptoms, which are reported by about 50 to 80% of the patients that have polycythemia vera, headaches, dizziness, blurred vision, and that's all going to come from that hyperviscosity. If you think about a normal fluid to cellular ratio, it's about a little bit more fluid than total cells. But in the case where you don't have enough fluid and you have an overabundance or hyperproliferation of cellular material, it's going to cause your blood to get a little bit thicker. You don't have that fluidity that you would normally have. Um, Headaches and dizziness and blurred vision could also come from not just the hyperviscosity, but from the increased blood pressure or the hypertension. So let's look at some laboratory data associated with polycythemia vera. First thing we're going to notice is an increased red blood cell count, hemoglobin increase, and hematocrit. We are also going to see an elevated white blood cell count and platelet count. Now, again, just like CML, PV also has some cytogenetic indicators. And this one is called the JAK2 mutation. What the JAK2 mutation does is essentially hijacks erythropoietin and causes erythropoiesis or hematopoiesis in the absence of erythropoietin. So when we need more red blood cells, our kidneys recognize the low oxygenation or the greater need. Erythropoietin levels increase, and then we become more proliferative in our blood cell per our need. However, in the case of the JAK2 mutation, I always remember it because JAK2 hijacks erythropoietin, and then it no longer becomes relevant to erythro or hematopoiesis. So what we will see in the bone marrow is a hypercellular bone marrow with an increased red blood cell and myelocytic precursors. We are also going to have low erythropoietin levels, and that's because our kidneys aren't producing erythropoietin. There's no need. There's nothing to indicate to the kidneys that we need to produce erythropoietin, and yet because of that JAK2 mutation, hematopoiesis continues at an alarmingly high rate. We are also going to have an absence or low level of hemosiderin in the bone marrow. So this is going to utilize all of our building blocks for hematopoiesis or erythropoiesis. And that is because when you're producing a high number of, I guess, products in the case of these cells, you use up all of your stores. You can't replenish them fast enough. So these patients are going to may become iron deficient. They're also going to have a high lap score and an abnormal platelet function. So let's look at some of the diagnostic criteria for polycythemia vera. Some of the major criteria is going to um, be related to hemoglobin. We're going to look at a hemoglobin of greater than 18.5 in males and 16.5 in females, or maybe some other evidence of an increased red cell volume. We're going to look specifically for that JAK2 variants or other functionally similar mutation like that JAK2 exon 12 mutation. And then we're going to look at some maybe more lab-oriented data, hypercellular bone marrow with prominent granulocytic, erythrocytic, and megakaryocytic proliferation. Now again, that particular criteria could be found in other myeloproliferative disorders, but we're definitely going to see a decreased serum erythropoietin level, so that's going to be a big indication. And then endogenous erythroid colony formation in vitro. So it's going to be, I mean, this is kind of that endogenous erythroid colony formation is kind of some other lab tests that we would do outside of the body. This is not going to happen in vivo. I don't want you to worry too much about that, but focus on the cytogenetic markers, what parameters are going to be increased or maybe decreased. What do our iron stores or hemosiderin in the bone marrow look like? What is the cellularity of our bone marrow? So keep all of those things in mind. Okay, so there are a couple of things that we need to talk about in terms of polycythemia. So polycythemia in general is an increase in hemoglobin and hematocrit or red blood cell mass. Now, polycythemia vera is that primary unregulated and neoplastic absolute increase in the red cell mass. And of course, also the other myeloid cells and platelets. But this is specifically associated with that JAK2 gene mutation. Now, there is something called secondary polycythemia, and this is due to tissue hypoxia in states such as high altitude, maybe heart valve defects, or pulmonary disease. So this is where your body starts to produce, for example, if you go to the Himalayan mountains and you're there, your body's going to start producing um, a lot more red cells, and so you may actually have a huge increase in your red blood cell mass simply because of hypoxia. Same thing if you have a heart valve defect, your heart might not pump efficiently, or maybe there's some regurgitation where it's not being forced out of the heart properly. And so in order to try to compensate for that deficiency, if you have an increase in red cells, it will keep you from becoming too hypoxic. And then we have something called relative polycythemia, not polycythemia vera, but relative polycythemia. And this is from good old-fashioned dehydration, because remember, in a normal sample, we have a good amount of water and we have our red blood cells and all of our proteins and our white cells. But if a patient becomes dehydrated, you're going to have a decrease in that water volume, and so that will therefore change the ratio between the plasma and the red cells, and then you'll have what's called a hemoconcentration or a Guy's-Box syndrome, which can be caused from stress polycythemia. So polycythemia vera is a true unregulated neoplastic or myeloproliferative disorder. Secondary polycythemia is a hyperproliferation of erythroid cells due to increased need or environmental um, issues or circumstances. And then relative polycythemia is due to that decreased plasma volume due to dehydration or hemoconcentration, etc. Now, let's look at some of the differences of polycythemia vera and the other types of polycythemias. So let's look first at the total blood volume. So we're going to have an increase in polycythemia vera. The others are going to be normal or decreased. So we're talking total blood volume that is circulating in the body. Total white count is going to be increased with polycythemia vera because remember, it is going to be associated with that myeloid line, whereas the other types of polycythemia, we're going to have a normal white blood cell count. Immature red blood cells, we might see them occasionally in polycythemia vera. We're not going to see them in the other types of polycythemias. Platelets will be increased, lap stain will be increased. Those things will be normal in other types of polycythemia. Erythrocyte sedimentation rate, or like we call them here, sed rate, will be decreased and will be normal in it will be decreased in polycythemia vera and normal. And the reason for that is because of the elevated red blood cell. So we measure sed rates as red cells fall out of solution. But if you don't have enough solution, if you think about those glitter wands, did you guys ever see those where you've got water and there's like glitter, and when you turn it one way, all the glitter starts to fall down into one end, and then you turn it. Well, sometimes the glitter will be too thick for an area, or maybe the wand leaked and then it doesn't move down the way it should. So that's why we would have a decreased sed rate. So think of your red cells as the glitter particles. If you don't have enough fluid for them to settle out of, then a normal sedimentation rate is not possible. Serum iron is going to be decreased in polycythemia vera because, again, it's just utilizing all of its resources as fast as it can. But in other polycythemias, we're going to have a normal or an increased iron. Erythropoietin may be decreased or completely absent, and that in polycythemia vera. And again, that's because that JAK2 gene mutation is going to hijack erythropoietin so that hematopoiesis can occur without the influence of erythropoietin. And then in other types of polycythemias, it will be normal or even increased. Blood histamine is going to be increased because, again, remember, basophils are associated with the granulocytic or the myelocytic line, and those are all going to be proliferated in abundance. So we're going to have more histamine due to that increase in myeloid lineages. It will be normal in other polycythemias. Unsaturated B12 binding capacity will be increased in polycythemia vera. It will be normal in other types of polycythemia. Again, that basophil count is going to be increased, and then other polycythemias, you'll have a normal basophil count. Hyperuricemia might be present or absent. It's hard to say. And then we have a normal hyperuricemia in regular polycythemias or other polycythemias. So, so there are several differences, but if you look at other polycythemias, you're not going to see cytogenetic mutations. You're not going to really see any proliferation. The only reason why it is considered a polycythemia is due to a problem between the red blood cell and the fluid portion of the total blood volume or total blood sample. All right, so polycythemia treatment and prognosis. So in the case of polycythemia vera, which is our primary polycythemia. It is genetically influenced. The primary control of polycythemia vera is achieved by therapeutic phlebotomy. So they take out the extra blood volume, and that will reduce both the red blood cells and the blood volume. Now, don't get this confused with hemochromatosis that we talked about in our red cell unit. We also use therapeutic phlebotomy in treatment for people with hemochromatosis, but hemochromatosis is not a proliferative disorder. It is an iron metabolism disorder. Now, we may treat polycythemia vera or primary polycythemia vera with chemotherapy to knock down that proliferation. The median survival time, if a patient is untreated and symptomatic, after diagnosis is only about 6 to 18 months. But with treatment, the median survival is more than 10 years. So that's a pretty huge difference. I mean, I don't know about you, but if I was able to live a pretty good quality of life, and I just had to make sure that I stayed on top of my treatment for polycythemia vera, I would definitely be happier to live for 10 years versus 6 to 18 months. Now, others may have a different view on that, and that is perfectly fine. That is why we need to advocate for our patients where they can play a role in making decisions in their treatment. However, for me, I would love to live 10 years versus 6 to 18 months. Some patients may reach that spent phase where the bone marrow becomes fibrotic and anemia develops. So again, another case of fibrosis in the bone marrow. We can also have thrombotic complications, which can lead to stroke, deep vein thrombosis, pulmonary embolism. It can cause a lot of problems. So in addition to treatment, a lot of times these patients will have to be monitored for their coagulation state. Primary myelofibrosis is the next myeloproliferative disorder that I want to discuss with you. So primary myelofibrosis is characterized by a systemic bone marrow fibrosis and extramedullary hematopoiesis. And again, extramedullary hematopoiesis is just another term for hematopoiesis occurring outside of the bone marrow. And that can happen in the spleen, the liver, some of the lymph nodes. And really it is quite fascinating that our body can compensate when our bone marrow starts to fail us. It will do anything that it can to keep us healthy and strong. But unfortunately, it can only do so much. Secondary myelofibrosis is caused by infiltrative disorders, including malignancies and infections, or exposure to chemical toxins or radiation. So we're going to see some similarities in myelofibrosis or primary myelofibrosis and aplastic anemia. However, with aplastic anemia, the bone marrow is going to look fatty and have decreased hypocellularity in the bone marrow. And in the case of primary myelofibrosis, we're going to see fibrotic tissue. Kind of looks like scar tissue, or just like all of these lines that are running through, those are fibers or fibrotic tissue. Patients with myelofibrosis may undergo temporary or permanent transition to polycythemia vera, or it might actually convert to CML. So remember we talked about in the introduction of our myeloproliferative disorders that a lot of times they will transition into either an acute leukemia or some other proliferative disorder. And the reason why is because everything is kind of related in the bone marrow. You have to have the proper signals, the proper cellularity. If you have any disruption in that balance, you can shift into another direction. And because of those cytogenetic influences, a lot of times there can be multiple conditions that are affected by the same cytogenetic mutation or marker. We don't really see, I guess we would say, We don't see it very often, but I guess about 1/5 of patients with polycythemia vera will develop myelofibrosis, and part of that is because it goes into it basically overworks the bone marrow with that proliferation of red cells, myeloid cells, and megakaryocytes. And I feel like it just utilizes up everything that's in there. It kind of dries it out. So it's like a, overworked horse. It just kind of falls over and it's like, I can't do this anymore. Um, but primary myelofibrosis is pretty uncommon. All right, just a disclaimer. I promise that no horses were injured in the making of this lecture. But let's move on with clinical signs and symptoms of myelofibrosis or primary myelofibrosis. So patients with myelofibrosis usually exhibit obviously progressive anemia, splenomegaly, and marrow fibrosis. And this is marrow fibrosis isn't just because it's been overworked, but it's also due to pathologic changes of those megakaryocytes. And we're going to talk more about that here in just a minute. So if we have a fibrotic bone marrow, and therefore we have decreased hematopoiesis, our spleen and our liver are going to try to compensate by performing extramedullary hematopoiesis. Now, if you remember back to our fetal development lecture or discussion about fetal development and hematopoiesis, remember our liver and our spleen both have capabilities of performing hematopoiesis. It's just as we grow older and our bone marrow is doing the job, it's not really needed, but the capability is still there. And in extreme cases, our body will compensate by reactivating those areas of hematopoiesis and utilizing them to a higher degree. Other things that we might see in patients with primary myelofibrosis is bruising or bleeding resulting from thrombocytopenia, maybe an abnormal platelet function, so they have platelets but they aren't working properly, or it could be a combination of low platelet count and dysfunctional platelets of the ones that are there. And due to the low platelet count or abnormal platelet function, about 1/3 of patients manifest purpura, which is kind of like petechiae or purpling, like little purple spots. About probably greater than 40% have osteosclerosis with bone pain, malaise, and leukocytosis. So obviously, if your bone marrow is fibrotic and you're trying to get through your life because your bone marrow is located inside of your bones, you may have some problems with pain and osteosclerosis. Okay, so let's take a look at primary myelofibrosis and the laboratory data associated with that. So we've kind of mentioned this before. The prominent or hallmark morphology with regard to our red cells is going to be teardrop morphology, and we're going to see that in peripheral blood smears. That is the hallmark cell of primary myelofibrosis, and that's because of those fibrotic bands that are inside the bone marrow, and the cells that are produced there, as they try to come out, they get caught on those fibrotic strands, and it pulls our red cell membranes into that teardrop shape. We may have leukocytosis, mild anemia, thrombocytosis, maybe panhyperplasia, so all the way across the board in the marrow. Those are all characteristic in the early stages of primary myelofibrosis. We may see some other things in the later stages, so extramedullary hematopoiesis, peripheral cytopenias, and myelofibrosis. Those reflect the changes seen as the disease progresses or as the condition progresses. And of course, like all myeloproliferative disorders, transitions among the different types of MPNs, and termination in acute leukemia or marrow failure are common. When we have primary myelofibrosis and then it moves into a marrow failure, again, they try to do that bone marrow aspiration and it will yield a dry tap, meaning there's nothing really in there anymore except some crunchy old fibrotic tissue. Let's look at the diagnosis of primary myelofibrosis. Um, so some of the major criteria, we're going to have that megakaryocytic proliferation with abnormal morphology. So this is why we have either a decrease or a dysfunctional number of um, platelets, because those megakaryocytes are the predecessor to the platelets. And it might not be so much that fewer platelets are produced, because we know this is a proliferative disorder, so megakaryocyte proliferation is going to be there, but because of the abnormal morphology, they might be removed from circulation. They may be completely dysfunctional, and they're usually accompanied with reticulin and or collagen fibrosis. So when we get to our coag unit, you're going to learn about how collagen affects coagulation, how it can be a facilitator for platelet aggregation, but we're not going to go into that right now. Just know that collagen can be associated with platelet function. So other major criteria, maybe it's not meeting the criteria that the other myeloproliferative neoplasms require for their major criteria. But again, I know that polycythemia vera is associated with that JAK2 mutation, but primary myelofibrosis can also be associated with that JAK2. And there may be other cytogenic mutations present as well. Okay, minor criteria, leukoerythroblastosis. That's pretty nuts. Anemia, increased serum lactose dehydrogenase, which is LDH, we just call it for short. And then splenomegaly. So diagnosis requires meeting all three major and two of the minor criteria for it to be confirmed as a primary myelofibrosis. Okay, so let's talk a little bit about prognosis and treatment for primary myelofibrosis. The median survival time ranges from about 4 to 5 years. And generally speaking, asymptomatic patients don't really require a treatment. We just kind of monitor them to make sure they're not transitioning into anything else. Treatment of myelofibrosis can consist of periodic transfusions of packed red cells, androgens, cytotoxic agents, and platelet reduction by platelet pheresis. So they might have an overabundance of platelets, but maybe they're not all functioning. So essential thrombocythemia, or sometimes that is called primary thrombocythemia, is characterized by a significant increase in the circulating platelets. Usually we see it in a number of about 1,000 or greater. Elevated platelet counts may be due to a reactive phenomenon. It could be secondary to a variety of other systemic conditions, and we'll talk more about those as we move along. Essential thrombocythemia is a primary disorder of bone marrow, and platelet count is elevated outside of a normal physiological response. So to recap, what that all means is sometimes we may see an elevated blood platelet count in the case of a patient who's just had surgery and has utilized a large portion of their platelets and then is compensating for that, or we call it rebounding. It might be that this patient has a stress response or a trauma response. Maybe they've been in a car accident or they've had a hemorrhage of some sort. So those are the kind of elevated platelet counts that we would encounter as a reactive phenomenon. So that would be due to a variety of conditions, but that is very different than essential thrombocythemia. This is a primary disorder, and it is a problem within the bone marrow, and the platelet count is elevated due to that bone marrow problem rather than the physiological response that we would normally see with a little bit more elevated platelet count. Okay, so let's look at some of the laboratory findings that are common in essential thrombocythemia. Typically, we have a very elevated platelet count, usually anywhere between 6 and 1,000. Platelet morphology reveals normal morphology for platelets, and bleeding time is normal. So it seems that it functions pretty, platelet morphology is normal and function is normal, with the exception of platelet aggregation in response to the agonist epinephrine. So there is an abnormal platelet aggregation pattern with epinephrine. Patients may also suffer from pseudohyperkalemia, and this might be a result of a release of potassium from those platelets during the preparation of the sample or the collection of the sample. Now, remember, red blood cells have a lot of intracellular potassium, but so do platelets. All right, so let's look at the criteria for diagnosis of essential thrombocythemia. You might also hear it called essential thrombocytosis. Both terms are correct and they are interchangeable. We're going to have a persistent elevation of platelets in the peripheral blood, of course. We are going to have a significant increase or hyperplasia of megakaryocytes in the bone marrow. And if you look back at that, I forgot to mention this, but if you look at the last slide that we looked at, you're going to see a huge clump of purple platelets. Those are actually, we call it sheeting, megakaryocytic sheeting. So you're going to see sheets of these megakaryocytes and platelets in the bone marrow. It may not meet criteria for the other MPNs, and again, demonstration of that JAK2 or related mutation, or in the absence of JAK2, no evidence for reactive thrombocytosis, for example, like inflammation. So remember, we talked about thrombocytosis could occur due to stress or trauma. Well, in this case, if you have no evidence of that, then we would look at potentially an essential thrombocythemia. We would look for the JAK2 mutation, and maybe demonstration of or related mutation, or maybe in the absence of. So we would have to take all of those findings into consideration. So the diagnosis requires meeting all 3 major and 2 of the minor criteria. And honestly, I don't know that they really split this up into major and minor criteria like they do in some of the others. So let's just say 2 of the 3 of the 4, or maybe there's another table that wasn't put into this PowerPoint. But either way, these are all going to be indicators for findings in essential thrombocythemia. Here we go again. Too much of a good thing becomes a bad thing. So the course of essential thrombocythemia is rather benign. So for the most part, it's not something that's going to cause immediate death or harm, and it does resemble that of PV, but it may evolve into another form of myeloproliferative neoplasm, and in some cases into an acute leukemia. So remember, we do have those acute leukemias that are associated with megakaryocytic proliferation and red blood cell erythroid proliferation. So those are the acute leukemias that we're talking about. So those would fall under the AML because they come from the myelocytic branch of the cellular family tree. So go back and review those FAB classifications for AML, and you will see where you have one that is associated with megakaryocytes, one that's associated with erythroid. You'll even have one that's, eosinophilic, one that is myelocytic and monocytic in combination, so myelomonocytic, one that's just monocytic. So go through and really think about what's happening And these are a few of the myeloproliferative disorders that can transition into those same AMLs that we talked about earlier in our leukemia unit. Okay, so I have a couple of case studies. The answers are posted, but I'd really like for you to read through each case study first, just to try to get your brain moving. If you get really stuck, we can talk about it. But in any case, I'd really like for you to try to answer the questions in the side margin based on the case study information. Okay, and here is the first answer for case study number 1. I'm going to let you guys work through these and we will talk about them at a later date or during the review session for our white blood cell exam. Okay, so moving on to case study 2. Again, I'm going to let you guys work through those. Thank you for spending the time to do these. I think they'll really benefit you. Practice calculating your lab scores. Practice with your various leukemias, go through all of the myeloproliferative disorders and kind of discern which ones differ from the other and how they're the same. And don't forget to work on your flow charts. In any case, if you guys have any questions, you can always email me or text me at my cell phone, or we can talk about it in class at a later date. I know for those of you who might not be present in class for one reason or another, I'm always available to you to email or text. So don't hesitate. I'm happy to be of assistance. So good luck on your case studies, and we will talk about myelodysplastic syndromes next time.